Hello, this is the Disease Mystery Digital Story titled Type 2 Diabetes in Light of Diet, Exercise, and Adiposity, and I am Brandon Sassouni. Introduction. Diabetes type 2, or adult onset diabetes, is categorized by consistently high blood glucose levels. In a healthy non-diabetic person, insulin is produced by the pancreas in response to glucose presence in the blood after consuming food. Thereafter, insulin surface receptors on muscle, fat, and liver cells then bind to the insulin released in the bloodstream and activate glucose transporters to come to the surface of the cell to deliver glucose from outside to inside the cells. This has the effect of removing and lowering the glucose levels from the bloodstream and allowing cells to have the necessary nutrients for metabolic activity and growth. In type 2 diabetes, however, cells become insensitive to insulin, so that even while insulin is being produced, the insulin signaling system is defective and not allowing glucose to enter the body's cells, which creates a buildup of glucose in the bloodstream. This high level of glucose in the bloodstream then interacts negatively with other components of the body, such as hemoglobin molecules, collagen, and endothelial cells. This very fundamental potential for damage throughout bloodstream and all cells it is connected to allows diabetes to wreak havoc in nearly every organ system. This is a picture depicting the insulin signaling within the cell, and here you can see the insulin and the insulin receptor activating a signaling cascade that then translocates GLUT4, which is the glucose transporter that brings glucose into the cell. In type 2 diabetes, the basic cellular process disrupted is the insulin signaling pathway, which in normal cells activates glucose transporters, such as GLUT4, an insulin-dependent glucose transporter. The capacity for glycolysis decreases in patients with type 2 diabetes because of the lack of glucose transported into cells. This can decrease the cell's ability to carry out its function and decreases ATP availability. Some hormones play a role in type 2 diabetes as well. Two in particular, GLP-1 and GIP, act as incretins. Incretins are gut hormones that are secreted from enteroendocrine cells into the blood within minutes after eating. One of their main physiological roles is to regulate the amount of insulin that is secreted after eating. GLP-1 stimulates the release of insulin by the pancreas after eating, thus it has the ability to decrease blood sugar levels. GIP acts directly on pancreatic isolates to stimulate insulin secretion as well. Both of these hormones are found in insufficient levels in diabetic patients. The major function of the cell that are disrupted by type 2 diabetes is the lack of the entry of glucose, which is the most efficient substrate for cellular function across all cellular metabolism and growth. Glucose is also used as the main carbon substrate for building other larger biomolecules in the cell, such as proteoglycans, and is used to regenerate antioxidant capacity. The impact of this disease is mostly on two major organ systems, although it affects the entire body. The cardiovascular system is affected because of the damage of diabetes and the elevated blood glucose levels inflicted on endothelial walls, which increases the risk for stroke and diabetic retinopathy, or blindness caused by damage to eye blood vessels. Additionally, the integumentary system suffers due to diabetic wounds that don't heal, and ulcers, which further invite infection and disease. The most major functions of the body that are impacted by the disease are vision, kidney function, and brain function. Elevated blood glucose levels additionally leads to muscle atrophy. In order to diagnose type 2 diabetes, there are a few methods which are commonly used, such as the fasting blood glucose level test and the gold standard method used today, the hemoglobin A1C test. For both tests, either a small blood sample from a finger prick or from a standard blood draw can be used. The test can be done at home or at a regular physician's visit or blood testing facilities. For the fasting blood glucose level test, the blood is measured for glucose content, and a reading of over 126 milligrams per deciliter is considered a diabetic level. For the HbA1c test, which is supposed to test for the amount of blood glucose attached to your hemoglobin and gives a roughly 3-month average view of blood glucose levels, a level reading of over 6.5% is used for the diagnosis. In recent years, pre-diabetic screening has also been common, with the corresponding levels of 100 to 125 milligrams per deciliter and 5.7 to 6.4% being used as the respective testing measurement windows for the fasting blood glucose test and the HbA1c test diagnosis to determine prediabetes. This is the blood sugar chart, which is used to determine where one falls within the normal, early diabetes, or established diabetes ranges. Currently, the most standard medical care to treat type 2 diabetes is the prescription of the oral drug metformin. In some cases, injectable insulin is also prescribed, even if the patients are making their own insulin. It is recommended that insulin should be considered if there is evidence of ongoing weight loss, or when A1C levels are not in control and over 10%, or similarly, when blood glucose levels are very high and over 300 milligrams per deciliter. Both drugs have been in use for over 30 years and are well understood. There are currently several treatments for type 2 diabetes. Acarbose is a drug that inhibits the function of the alpha amylase enzyme and therefore decreases the absorption of glucose from a meal and postprandial glucose levels in diabetic patients. SGL2 inhibitors work by preventing the kidneys from reabsorbing glucose back into the blood and increase its secretion in the urine. In 2009, the FDA approved GLP-1 receptor agonists in the treatment of diabetes, which would force activate the receptor of GLP-1 to be activated and increase the release of insulin after eating. There are many approved drugs which act as DDP4 inhibitors, which increase mass and function of pancreatic beta cells, as well as increase insulin sensitivity in the liver, muscle, and adipose tissues. Metformin, the most popular and widely prescribed diabetes drug, acts by a few mechanisms, including DDP4 inhibition, and has the net effect of increasing the body's sensitivity to insulin. In type 2 diabetes, drugs should not be the only solution, though, as dietitians should also play a role in managing the disease, as weight loss is significantly proven to help diabetics on average reduce complications and lower their blood glucose levels. In type 2 diabetes, it is understood mainly as a disease that is acquired later in life, due to complex interactions between multiple genes and environmental factors. While recent evidence has been accumulating to show genetic variations that can make people more likely to acquire type 2 diabetes later in life, type 2 diabetes is not a disease for which it is recommended to do genetic testing for. Type 2 diabetes is much more of a phenotype for a myriad of possible underlying causes than it is a name for a genetic disease. There are quite a number of genes which play a large role in glucose digestion, transport, signaling, and metabolism, which could be important to test for nonetheless as risk factors for type 2 diabetes. So while there is not a standard genetic test, one could feasibly be developed to pre-screen people for determining their likelihood of developing type 2 diabetes based on both genetic risk factors and a scenario matrix with other known risky lifestyle factors and biometrics. Known genetic mutations which could affect type 2 diabetes risk are the hepatocyte nuclear factor 1A and the glucokinase gene, as well as calpain 10 and transcription factor 7 like 2. It was also found that a mutation in the PPAR-G gene led to a 20% increase in the risk of diabetes. A study done on a population of Pima Indians showed an effect of maternally derived KCNQ1 gene variants, which appeared to be mediated through decreased insulin secretion and is particularly strong, accounting for 4% of the variants in liability to diabetes. Multiple studies have implicated genes affecting premature insulin receptor internalization prior to insulin binding as a potential mechanism underlying insulin resistance. A critical role of spindle checkpoint regulator proteins in insulin signaling and metabolic homeostasis through regulating endocytosis of the insulin receptor has been shown, which could influence type 2 diabetes. Centromere protein A is another cell cycle protein which has been interestingly shown to be required for chromosome segregation during the M phase and necessary for adaptive proliferation in insulin-producing beta cells. The insulin-stimulated SENPA protein gene expression is blunted in isolates from patients with type 2 diabetes and is an essential component in the beta cell adaptation to delay and/or prevent progression to diabetes. While type 2 diabetes is not inherited nor sex-linked, or linked to any chromosome or genetic locus of interest even, as with most diseases which are most strongly correlated with onset at a higher age, we can assume that the accumulation of genetic mutations and epigenetic dysregulation must be playing a causative role over and above purely lifestyle choices and other phenotypical biometrics. In any case, there is no single gene which accounts for or is even associated with the majority of diabetic cases, and so it is still largely considered a non-inherited lifestyle or acquired disease. Lifestyle factors such as excessive stress and lack of sleep are known to be risk factors for increasing the likelihood of acquiring type 2 diabetes. In one study, stress was shown to have a major impact directly on HbA1c levels and indirectly via decreased treatment adherence. Shorter and longer durations of sleep had been adversely related to insulin resistance as well. Moreover, obstructive sleep apnea is one of the most common sleep disorders and is characterized by chronic intermittent hypoxia and increased sympathetic activity, often leading to a higher prevalence of diabetes. Another study confirmed significant subjective sleep disturbances in both quality and quantity in patients with type 2 diabetes were associated with poor diabetes control. More important than any other risk factor, however, for type 2 diabetes are caused by and associated with lifestyle habits that most likely have to do with lack of exercise, excessive calorie consumption, and weight gain. The most consistent advice to type 2 diabetic patients is to exercise and lose weight, and for good reason. Results have shown that, in fact, obesity and physical inactivity interact on an additive scale towards type 2 diabetes risk. This means that prevention of either obesity or physical inactivity not only reduces the risk of diabetes by taking away the independent effect of this factor, but also by preventing the cases that were caused by the interaction between both factors. While type 2 diabetes is often thought to be caused by excessive sugar consumption, this has been disputed and shown to not necessarily be statistically significant or causative alone. Evidence shows that consumption of excessive calories in a high-fat diet with high saturated fats is also an important risk factor alone and does indeed reduce insulin sensitivity. Due to the statistically significant and seemingly causative link between obesity and type 2 diabetes, it could be said that genes which increase the risk and are known to cause excessive weight gain could also be considered genetic risk factors for type 2 diabetes, or at least be a logical hypothesis to do further testing on. In my opinion, an extremely promising gene of interest for type 2 diabetes would be the PCK1 and PCK2 genes, as these genes are involved in gluconeogenesis, which is known to be elevated on average in type 2 diabetes and which serves as the de facto most direct source of consistently increased blood glucose levels in absence of lifestyle dietary decisions. Moreover, PCK2 genes have already been linked to increased obesity risk and therefore fit the criteria for the previous hypothesis. Another potentially important set of genes known as uncoupling proteins would also fit this criteria. Biologically, UCPs play a role in thermogenesis and mitochondrial respiration and metabolism of glucose. Briefly, UCPs can expend the proton gradient force to generate heat, and in doing so, enhance the efficiency and rate of metabolism in most ways except in adding to the total production of ATP. Because UCPs quite literally aid in the burning of excessive energy sources such as fats, their dysfunction and downregulation has also been shown to be linked to obesity risk. Furthermore, this same underlying issue could cause a decrease in glucose metabolism capacity. UCP3 plays a role in fatty acid metabolism and energy homeostasis and modulates insulin sensitivity as well. Several gene polymorphisms of UCP1, UCP2, and UCP3 have already been reported to be associated with diabetes and should be further studied. Herein we see the mitochondrial electron transport chain and the proton motive force, which can be dissipated through UCPs to produce heat instead of ATP. In researching potential future therapies for type 2 diabetes, a new approach which seems very promising seems to be to increase the amount of brown fat in an individual. Brown fat differs from white fat in that instead of serving as a storage cell for fat in the body, it actually serves to burn fat, mainly to produce heat. It has been shown that in both type 2 diabetes and obesity, which is the major risk factor for type 2 diabetes, that brown fat is decreased and white fat is increased compared to normal controls. Brown fat, both directly through increased metabolism and indirectly by helping to possibly reduce the weight of the patient and increase insulin sensitivity, could be exactly what is needed to treat type 2 diabetes. A specific attempt by Harvard researchers to mimic brown fat by injecting white adipocytes which overexpress the UCP1 gene, the gene responsible for increased exothermic metabolism, and which is also shown to be downregulated in type 2 diabetes, showed promising results in preclinical animal studies of diabetes treatment. Another study gives support to this approach and discovered that UCP1 overexpressing adipocytes significantly improved glucose uptake by 40%. Another animal study with a slightly different approach generated transgenic mice expressing the mitochondrial uncoupling protein in skeletal muscle. Skeletal muscle oxygen consumption was 246% higher in mice with high expression of UCP compared to wild-type mice. UCP transgenic mice fed a chow diet had the same food intake as wild-type mice, but weighed less and had lower levels of glucose and triglycerides and better glucose tolerance than did control mice. Interestingly, pigs lack UCP1, and a study using CRISPR technology to create gene-modified pigs showed these pigs regained UCP1 gene expression and showed that these pigs accumulate less body fat. While other modern approaches looking forward to treat type 2 diabetes seem largely focused possibly on targeting and increasing the number of insulin-producing pancreatic beta cells or enhancing the use of exogenous insulin, either by creating automated insulin delivery systems and even combining those with artificial intelligence software to create what is termed an artificial pancreas, or by making insulin easier to use and expanding its market into type 2 diabetes by turning it into a bioavailable pill form, these approaches still mask the disease rather than trying to start to cure it. Nevertheless, they will be vital to the near and medium-term management of disease and help people most likely maintain more consistent lower blood glucose levels. In conclusion, type 2 diabetes is a relatively common disease which is easily diagnosed and for which many known risk factors exist. Above all, it seems that the sensible approach to managing diabetes remains via losing weight and exercising, as these have synergistic and definitively positive benefits with virtually no negative side effects. However, looking towards modern medicine, we should wish to do more, and by understanding the processes through which weight gain may be exacerbated and cellular energy usage decreased in diabetics, it would be wise to invent treatments which would help patients simultaneously lose weight and increase cellular respiration and glucose utilization. For these reasons, it seems that increasing fat-burning brown adipose tissue and decreasing fat-storing white adipose tissue in type 2 diabetic patients, possibly via increasing UCP gene expression, is an invaluable medical goal, as this can go very nicely in line with the traditional recommendations of diet exercise to further synergize and safely burn additional calories and put cells to work in a way that mimics exercise. Thank you, and here are my citations.